I'm super excited. I'm super excited about the release of Carr's Coda Clinic. I had the absolute pleasure of interviewing Sarah, Tarlan, and Swami, and I can't wait for you to hear the sections for those who missed it. But what I'm even more excited about is that Coda 22 is back. Now, I'm hoping I have a haircut by then, and I'm hoping I'm going to see you in Melbourne on April 3rd to April 6th, 2022. Book off your time. We're working on the program. It's coming together. It's going to be an unbelievable time. It's a reunion. We all need this. We all need you to be there. So take a look at codachange.org for details, but I can't wait to see you down under in just under a year. See you soon. Dr. Tarlan Hedayati. I have been looking forward to today. A legend, someone I couldn't wait to talk to, Cook County's finest, the chair of education, the big shot at every conference I get to hear to, and I get to talk to you today. And I understand you have a beef. You have a problem. Tell me about it.
We're about to get into it. So, bias by design. Let's chit chat a little bit. I'm going to throw a case at you and tell me what you would do. All right, here we go.
Awesome.
So let's say you're working in the emergency department, or I think you guys call it emerge.
Emerge. Yeah. Okay. Up north.
Or A&E.
Perfect.
So let's say you have a patient comes in, they are complaining of some shortness of breath, and you ask for triage vital signs. And when I say triage vital signs to you, what measurements are you looking for?
Yeah, everything. Fortunately, we're done with that pain vital. Heart rate, blood pressure, temperature, rest rate, O2 sat. I love rest rate because the nurses always make it up, but stats are super important in that patient.
I'm so glad you said that. And that's what I wanted to hear. So let's say it's a patient who's coming in with an acute asthma exacerbation. So pretty bread and butter emergency medicine. And you provide all your standard treatments. Their wheezing is better. They feel better and they want to go home. Do you have a threshold pulse oximeter measurement that is the level under which you would say, I think I'm going to admit this patient?
Yeah, barring all the social stuff and the fluff, probably somewhere under 94, and I get them to walk, and if they're not too low, I try to get them home if they have good follow-up.
Yeah, perfect. Me too. So, 93% I'm comfortable with too. So yeah, so we have a similar threshold. So let me tell you this, or let me ask you this. Let's say that I told you that this vital sign, the pulse ox measurement in this dyspneic patient, that's going to kind of help you figure out what the disposition is going to be, is flawed, is biased, and could potentially harm your patient.
You're screwed.
Yeah, we all are. And even worse, your patient's screwed. So let's dig into this.
Yeah.
So the pulse ox value is basically, a percentage of the hemoglobin that's saturated with oxygen. So in the arterial blood, and that normally runs 94 to 100%. That's why we all kind of have that threshold around 94%, under which we're like, I'm not comfortable with this. Now, do you know how a pulse ox works?
Do I have a phone a friend option?
Yeah, I'm your friend. Guess what? I'm your friend.
Tell me, because
Yes.
I know
Here
it's like some weird thing and there's a red light and it pages the medicine resident and it tells you the answer.
Yes.
I have no idea.
Close.
Okay.
So basically the device shines a red light and an infrared light, and it goes from one side of the finger, or if it's on the toe, one side of the toe or the ear. And it measures how much of each of these lights, the red light or the infrared light, is detected on the other side, after it's passed through and been absorbed by muscle, by bone, by blood, everything in between. And it does this like magical calculation and comparison between the red light and the infrared light. And then it spits out this number at you that correlates with the arterial oxygen saturation. So pretty cool, right?
Yeah, perfect. Continuous monitoring, easy. We always do this. Love it.
Yeah, we love it. But here's the problem. So what's the first thing the light passes through?
Oh, you're going over anatomy, aren't you? The epidermis, I don't know, the skin?
The skin, I love it. Yeah, see, I'm just going to throw like softballs at you here. So the first thing the light passes through is skin. Yeah. And what we know and what we've known for a long time is that the pulse oximeter is inaccurate in non-white people. So let that settle in. This is not an accurate measurement in non-white people, particularly at lower saturations, because these devices were designed and then tested with white people in mind.
So I've heard this ish lately with all this extra care about monitoring and stuff like that. But are you just saying this or is there actually papers in science about it?
There are papers. Let's get into it. So we have some recent data, but this is something that we've known for a long time. So when you dig back into the literature, you find anecdotal evidence and comments and various papers. And it goes back to like the late 80s, 1990s. So a while ago.
Before evidence-based medicine.
Yeah, I think it was that. I think we had it back then too, but we just sort of accepted it. Yeah, ish. We just sort of accepted it. It was just kind of a line buried in the middle of a paper. But then in 2005, a group of researchers kind of got together and they were like, hey, let's take a look at this and really dig into this. So it was a group of physicians at the University of California in San Francisco. They designed a study specifically looking at pulse ox accuracy in 11 dark-skinned subjects and then 10 light-skinned subjects. They were all volunteers, all healthy, and they used 3 different pulse ox models. And what they did was they had these volunteers inhale this like air, nitrogen, carbon dioxide mixture, and then they sort of tweaked the oxygen concentrations and then measured what the O2 saturation was on a pulse oximeter and what the measured O2 sat was on an ABG.
So basically, the REB allowed them to poison individuals, make them hypoxic, and then compare them. Tell me this was something worthwhile and they found something meaningful.
In the name of science, yes, they did. So what they found was that the effect of that skin pigmentation on the discrepancy increased almost linearly as the arterial oxygenation decreased. So there was this discrepancy between the pulse oximeter and the measured arterial oxygen saturation. And as the arterial saturation decreased, that discrepancy got wider and wider and wider.
And this is similar to the New England paper, correct?
Correct. Now, interestingly, these same investigators then put on a similar study maybe 2 years later, and they included more patients. Now they threw in 36 patients. And what they did this time was they said, all right, we're not just going to have dark and light. Now we're going to create this intermediate category. And what did they find? Basically, the pulse discrepancy, the pulse ox discrepancy, or bias, let's call it what it really is, was generally greatest in dark-skinned subjects, and it was intermediate for the intermediate skin tones and least for lightly pigmented subjects. And the bias grew significant at lower oxygen levels, so at around 90, and then got widest in the 70s. And those adhesive stick-on sensors, those performed the worst compared to the clip-on variety. Now, in this 2020 paper that you mentioned, and I'm so glad that you did, that was at the University of Michigan in the midst of the pandemic in the US, a country that's been completely devastated by COVID. And the results were even more meaningful. So in the US, we know already that COVID has disproportionately affected brown and Black patients.
Yeah, I mean, I think all over the world, what really frightens me is, and I don't have shares in Amazon, but I've been telling all these patients to go buy SAT probes at home because this was going to help determine whether they needed DEX or something crazy like that.
Absolutely.
Am I going to get screwed?
You may, and your patient's about to get screwed too, because here's what happened is, yeah, we told them all go out and get these pulse oximeters and track your pulse ox at home and kind of use that as a gauge as to when you need to come into the hospital to get admitted and get supplemental oxygen and the whole 9 yards. Now, this New England Journal article, this was a huge retrospective study. Over 10,000 ICU patients at one hospital, all requiring oxygen. And then they had another 37,000 plus cohort across over 170 ICUs. So this is a pretty mega study. And they compared pulse ox measurements against measured blood gas saturations. And they did it within 10 minutes of one another, which some may argue is kind of a large time gap. What they were looking for was occult hypoxemia, or an ABG O2 sat that's less than 88% when the pulse ox is telling you that the SAT is 92 to 96%. So you can see that's a discrepancy. So on the ABG, less than 88%, but on the pulse ox, it's reading 92 to 96%. What they found was that Black patients had nearly 3 times the rate of occult hypoxemia that was not detected by those pulse oximeters compared to white patients. And then when they trended the pulse ox and the ABG readings, on average, they found a bias of about 2% between the ABG and pulse ox saturations. So I'm going to flip this in kind of a different way just to drive this point home. There was a commentary that was put out by the British Medical Journal in response to this article that was published in the New England Journal. And if you think about it, to qualify for something like home oxygen, the patient has to hit a certain threshold of oxygen saturation. And for most, the saturation is 88%. Now, on a pulse ox, that means that for our Black patients, some of our Black patients will have to actually hit an arterial O2 sat of 86% or maybe even lower so that it shows up as 88% or lower on a pulse oximeter. And what has just happened is we have introduced bias. We have established now essentially 2 separate standards for patients based on color.
It's frightening. And I can tell you with COVID and our treatment algorithms for people qualifying using pulse ox to determine the need for additional meds is frightening. Now, I always liked ABGs because I was a mediocre med student and I used to have 4 chances, 2 radials, 2 ulnars to hit it. But ABGs suck, Tarlan. They suck. Tell me you're not going to recommend ABGs.
I don't want to recommend ABGs. And I'm glad that you only went for like the radials. You know, some people like to go for the femorals too. Now, we can use ABGs, but now we're subjecting a patient to this like painful, invasive procedure that just because we have this like flawed and biased device that we use that is critical to patient care and critical to our medical decision-making. And where we really need to put forth our efforts is rather than subjecting the patients to this unnecessary procedure is let's take a look at these devices. Now, the governing organizations that, test the devices and then approve the devices along with the device manufacturers, they need to acknowledge this bias in their design and then go back to the drawing board and correct the flaw in their products.
So industry, science needs to make a change. Tarlan, give me the bullets, give me the wrap up. We got intensivists, anesthetists, emerge docs, healthcare workers. What do they need to hear? What do they need to remember?
For now, you can obviously still continue using the pulse oximeter. Just keep in the back of your mind that that number that it's giving you may not be an accurate representation of arterial oxygen saturation in some of our Black and brown patients. And that number may actually be lower than you think. And in some, about 2 to 3%, maybe even more. The pulse ox is great for trending saturation and tracking saturation. Now that we know that there's this racial bias in this particular device and it's going to impact our medical decision-making, 1, what are we going to do about it? 2, what other sources of racial bias do we have in clinical medicine that we haven't even considered or acknowledged yet?
Food to think, things to digest. Really happy you brought that up. I think it's going to rethink the way I start monitoring patients. Thank you so much for speaking. I can't wait to see you down under in person, maybe next year at CODA. Please be well, stay safe, all the best.
Thank you. Thank you. You too, David. Thanks for having me.
Okay, take care, Tarlan.